Good day, and welcome again to Learning Pharmacology with me, Nurse Myron. For today's learning activity, we will be discussing antifungals. For our full disclosure, I am not affiliated with any of the manufacturers of the drugs or other items mentioned in this lecture. The mention of such brand names are only in passing and for educational purposes only, and are not for commercial promotion. I have no actual or potential conflict of interest in relation to this presentation. So let us begin with a review of the microbiology of fungi and some common fungal infections. Fungi are a diverse group of organisms that are characterized by a rigid cell wall composed primarily of chitin and polysaccharides. Their cell membranes contain a unique sterol known as your ergosterol. Fungi are considered as eukaryotes. They include yeasts, mildews, molds, and mushrooms. They are virtually found all over the planet, but they prefer warm, moist, and dark environments. These are the locations where they not only live, but they thrive. Fungi cannot produce their own food. That is why they are known as heterotrophic organisms. They rely on host organisms for food and survival and eventually for reproduction. Most fungi are either beneficial or neutral to man. Beneficial fungi are used for food or even medication production. However, some are harmful to humans. They can cause infections known as mycosis. These infections can range from superficial, meaning they affect the skin and mucous membranes, to the more potentially life-threatening diseases known as your systemic infections. These are commonly seen in immunocompromised individuals. So these are some of the examples of products of your beneficial fungi. Most of them are food like your enoki mushrooms or the yeast needed to produce beer and even bread, and also your toyo or soy sauce, and even cheese production. Some fungi are also used to produce drugs like your penicillins. While most fungi are beneficial for humans, some are harmful and are considered as pathogenic fungi. Common bad fungi include your Candida species, which cause candidiasis, sometimes known as oral thrush or vaginal thrush. We also have your Aspergillus species, which can cause aspergillosis in the lungs. Cryptococcus neoformans can cause cryptococcosis, also primarily found in the lungs or occasionally in the central nervous system. Histoplasma capsulatum can cause histoplasmosis, which also affects the lungs. Blastomyces dermatidis can cause blastomycosis, primarily affecting the skin. Other fungi classified as dermatophytes, like your Trichophyton species, are responsible for fungal skin infections, like some cases of athlete's foot or ringworm. Melassezia species can cause your Tinea versicolor and other yeast skin infections. Tinea, commonly known as your ringworm, are technically not real worms. They are actually fungi. However, because of their circular formation, the lesions they produce somehow resemble worms. That is why they were called ringworms. In Filipino, Ringworms are known as your buni. These can be further classified based on the location. For example, Tinea pedis is known as athlete's foot. Locally in Filipino, this is known as alipunga. These are commonly found in the areas between the toes, which is mostly dark, moist, and warm, areas that fungi really adore. Tinea capitis, from the name caput meaning head, are the fungal infections on the scalp. They are sometimes known as your scalp ringworm. Tinea versicolor are multicolored skin patches often found at the back or sometimes on the chest. And lastly, your Tinea cruris is fungal infection of the groin area. These are known as your jock itch. So these are some of the So here in this slide you can see some photos of these common fungal infections that we have discussed. Like number one, you have your scalp ringworm or Tinea capitis. Number two, you have your athlete's foot or Tinea pedis. Number three, you can see the multicolored patchy fungal infections on the back of the client, known as your Tinea versicolor. Number four, you have here your jock itch or Tinea cruris. And lastly, here in number five is the fungal infection of the nails, which can affect either the fingernails or toenails, where the surface of the nail typically becomes yellowish or brown, sometimes even white. They are brittle and they break easily. These are known as your onychomycosis. Another common infection is your Candida albicans. Albicans from albus meaning white, because typically these fungi are white in color. These are normally harmless, known as your normal flora. However, under certain circumstances, they can become opportunistic pathogens. For example, when there is an alteration in the pH level of the vaginal area of a woman taking oral contraceptive pills. These Candida albicans, normally harmless, can suddenly become opportunistic. They are mostly found in warm, dark, moist environments, such as the areas under the breasts or skin folds, and even in the skin folds of the vaginal area. They can also be passed to another person who engages in oral sex. Candida infections can cause red rashes and even itchiness. So who now are most at risk for developing fungal infection? Primarily, persons who are immunocompromised, such as people living with HIV and AIDS, are most at risk. Other people include those who take immunosuppressant drugs, such as your steroids. These include patients with cancer, those receiving chemotherapy, or other drugs, such as, for example, in cases of asthma. Also at risk are those of extremes in age, like the very young and the very old. So let us now discuss the pharmacodynamics of your common antifungal drugs. The common problem with antifungal drugs is that fungi and mammalian cells are both eukaryotes. They both share fundamental cellular characteristics. The challenge is it is difficult to produce drugs that are selectively toxic to fungi but not to human cells. Scientists and physicians have identified that fungal cells have the rigid cell wall and the distinct cell membrane that we have mentioned earlier. This has now become the target for the drugs against fungi. Cell wall in fungi contain chitin and polysaccharides. In a way, these act like the turtle's shell, protecting the fungi. Secondly, fungi cell membranes contain a phospholipid bilayer known as your ergosterol. These function to maintain the cell membrane integrity, protecting the cells of the fungi. Therefore, drugs that are developed to combat fungi must be potent enough to break down these barriers, primarily your ergosterol, but they should be safe to protect human cells. So we can see here in this slide that the cell wall of fungi contain your rigid structure made of chitin and polysaccharides and your ergosterol. So these are the targets of the antifungal medications. So now we can classify these common antifungal agents. We can divide them into the systemic and your local antifungals. Systemic antifungals are given for systemic mycosis. Since these drugs are intended for widespread fungal infections all over the body, they are powerful and they are potent, meaning they can also be toxic against the host or the patient. These drugs require the prescription of a doctor and a written order before administration. Likewise, to ensure the effectivity of systemic antifungals, a patient needs to have culture and sensitivity testing before the administration of these drugs. On the other hand, local antifungals are mostly given for skin and mucous membrane fungal infections. Most of these drugs are available over the counter. They are easy to apply, have minimal side effects, and do not necessarily require a culture and sensitivity before administration. So in this table, we can see the common classifications of your antifungal drugs, the mechanism of actions, and some representative drugs under each category. So for example, we have your polyenes, which reacts with ergosterol, thereby disrupting the cell membrane structure of the fungal cell. Under this, we have your amphotericin, one of the most powerful systemic antifungal drugs, and your nystatin. We also have your echinocandins, which interfere with cell wall synthesis. This category includes micafungin, capsofungin, and anidulafungin. Next, we have your antimetabolites, which inhibits protein synthesis. For example, your flucytosine. Then we have your alliamines, which inhibits ergosterol synthesis, like your terbinafine under the brand name Lamisil. And one of the most popular category, you have your azoles. Like other classifications, azoles disrupt ergosterol production. So under azoles, we have two further subclassifications. You have your imidazoles, like your ketoconazole, very common, very popular under the brand name Nizoral. You have your clotrimazole, brand name is Canesten, a common ointment given for skin fungal infections. You have your another common ointment or cream, your ticonazole, under the brand name Trocid. And lastly, you have your miconazole, also common for skin infections under the brand name Monistat. Your triazoles, the representative drug here is your fluconazole. The popular brand name is Diflucan. This is available in oral form and sometimes in injectable forms. So delving deeper, we have your azoles. To easily remember this, just remember that there is a fungus or fungi in your azole or your azole, no? because the rectal area is warm, dark, and moist, and fungi adore this area. Okay? So as was mentioned in our table, common drugs under your azole category, you have your ketoconazole. So you can see here the Nizoral brand available in oral form and also as a shampoo for scalp fungal infections. Then we also mentioned your diflucan or diflucan, the brand name for fluconazole, which can be given orally as a capsule and intravenously. So take note, however, that diflucan is quite nephrotoxic. Itraconazole, another common azole, sold under the brand name Sporanox, is also given orally, but is likewise hepatotoxic. Therefore, the nurse must closely monitor both the liver and the kidney functions of the patient, monitor urine output, and even your liver enzyme laboratory results. One common side effect of the azole category is they block the body's natural sterols like your cholesterol, including your testosterone and steroids. Therefore, possible side effect includes central obesity. My fellow nurses, however, I want you to be cautious with azoles. Please do not confuse them with similar sounding drugs. For example, your omeprazole and other similar proton pump inhibitors like lansoprazole and esomeprazole, which end with prazole versus your antifungals azole. Okay, so to remember this, remember pra. Okay, prazole, as in omeprazole, lansoprazole, esomeprazole. These are proton pump inhibitors. Remember the PR, pr. Okay. Another drug you should not confuse your azoles is your metronidazole. Okay. So azole versus dazole. Remember that metronidazole is given as an antibiotic and sometimes or actually quite commonly given for amoebiasis, which is a protozoa. The causative agent is your Entamoeba histolytica. So again, azole, antifungal versus dazole, your antibiotic for amoebiasis. Lastly, do not confuse your clotrimazole, antifungal, versus cotrimoxazole, an antibiotic under the category sulfonamide. Okay? So again, be careful. We have many similar sounding and even similarly spelled drugs that you can be easily confused. Okay? So next we have your polyenes, and these drugs include your nystatin or nystatin. Okay, this is a commonly given oral medication for fungal infections in the skin and mucosal membranes, especially of the mouth. In certain cases, fungal infections like your Candida thrush, which can be acquired or transmitted via oral sex. And this can be also administered as a prophylactic agent. Nystatin is also given for immunocompromised patients such as people living with HIV/AIDS or those receiving chemotherapy because of cancer, and in certain cases, infants and very young children. So nystatin, so you can see here the common brand name is Afunginal, okay, is usually a milky, pale yellow, sometimes whitish solution that can be given as a gargle or topical ointment or in certain cases an oral tablet or for the vaginal variant of the fungal infection as a vaginal tablet. So instructions for giving oral nystatin includes shake the solution well because the suspension may not be homogeneous if not shaken well, and therefore the effectivity may be decreased. Then take the necessary amount but do not swallow immediately. You need to swish, gargle, play around with the drug inside the oral cavity. Then, depending on the order of the doctor, you can swish and spit, meaning you can gargle then luwa or dura the nystatin, or swish then swallow. Okay, the latter method is more indicated for fungal infections deeper in the oral cavity, for example, the throat or the tonsil area. Okay, so remember, shake, then swish and spit, or swish and swallow. So now we move forward to perhaps the most powerful, the most potent systemic antifungal drug available, your amphotericin B. Remember the B? It is bad. Very, very bad. It is sometimes called your amphoterrible. Okay? So amphotericin is given intravenously. However, take note that when giving this drug, it should be very, very slowly. Okay? This is indicated for severe systemic fungal infections, and because of its potency, it is highly nephrotoxic and hepatotoxic. So side effects include headache, nausea, vomiting, diarrhea, dyspnea, chills, and even dyspnea. Okay? Because this is a very potent antifungal drug, when giving this to patients, some physicians will order a pre-medication of paracetamol to prevent the chills and fever, steroids like your dexamethasone to prevent the other side effects like headaches, even nausea, vomiting, and your antihistamine, including your diphenhydramine, to prevent other allergy-like effects of amphotericin or your amphotericol. So for your nursing considerations in giving systemic antifungals, of course, always obtain a culture and sensitivity test of the fungal infection to check if the drug, especially your amphotericin, will really be effective against the infection. Okay? So patients with fungal infections are typically your immunocompromised patients. Therefore, closely monitor them for any other secondary infections. Remember also, because of the potency of these systemic antifungals, to avoid giving them during pregnancy and lactation. The only antifungal that may be given, of course with the doctor's order, in extreme cases for a pregnant woman or a lactating mother is your terbinafine. This is only indicated for life-threatening fungal infections. Because most antifungals, especially your systemic antifungals, are nephro and hepatotoxic, nurses should closely monitor the liver and kidney functions. So remember that the right antifungal should be given against the right fungus. As nurses, we should emphasize that the patient should complete the duration of treatment. So if the physician will prescribe 10 days, usually the drug should be given 10 plus 2 more days to make sure that all presence of the fungus or the fungi in the body are eliminated. Educate our patients that antifungal treatment is typically long-term. sometimes weeks, or even in certain cases, it can be months. So remember all these as your nursing considerations when giving antifungal drugs to your patients. I hope that you learned a lot today in our discussion. Thank you very much and enjoy learning.